Sure, I'll make it a quick one. So, so I was, this is a new topic. So I was really wondering what are the alternatives to liver transplant, and would you do it if there were alternatives at all? And then, I figured that there will be alternatives depending on what etiology. Oh, where's the thing? Projection? Okay. So the alternatives could be either because of the etiology of liver disease or maybe because of the indications of liver disease. So, these are the two groups under which we are going to discuss some of the alternatives. So, either you have, if there is somebody with alcoholic liver disease, you have the alternative of abstinence and then nutrition support, and sometimes they can avoid a transplant. If you have NASH, then you can control your weight, control your diabetes, some very good anti-obesity and anti-cholesterol drugs available, and you can avoid it. Hepatitis B and C are prime examples of how good antiviral drugs have transformed these two diseases. So we used to do transplants almost up to 45% for these two viral etiologies, and now they are both down to less than 10%. So we know now that successfully treated viral hepatitis can actually reverse fibrosis also. So therefore, there is potential for reversal of fibrosis in other metabolic diseases too, although lesser than in viral hepatitis. We know for biliary atresia we have Kasai, and then for metabolic liver diseases there is a huge potential, although not clinically realized right now, but there is obviously diet, so you avoid a certain diet lifelong and then you can avoid a transplant sometimes, but often it's not possible because of availability of diet or late diagnosis. There is some evidence that we could do enzyme replacement of some metabolic diseases, but the huge opportunity is hepatocyte transplant and gene therapy, especially for the monogenetic defects. Now, there were two groups that have been primarily working on this. One is Ira Fox in UPMC, Pittsburgh, and the second is Dr. Anil Dhawan in King's College. And the King's College group has really seen some good success, about 8 patients who have done well with hepatocyte transplant. Although they don't have sustained effect, so they will need long-term repeated infusions, which we are going to discuss those. And similar to the xenotransplant, the technology of CRISPR-Cas9, which has only been around for about 10 years now, has the potential to really give us, it's a great tool to take care of the genetic defects, and it will happen very soon at some point or the other. We know how to manage a decompensated liver disease, but this is something that we do all the time. And there was a promise at one point that patients with decompensated liver disease will have liver dialysis or Mars or Prometheus. They came in different flavors. And unfortunately, except for reducing their bilirubins and reducing their ammonia, which led to better encephalopathy, it didn't do anything. So it didn't improve their survival, it didn't do anything else. In fact, in acute and chronic liver failure, Mars was harmful compared to standard medical therapy. Similar to what we are realizing with plasmapheresis now. So it didn't really live up to the promise of liver dialysis, and then we imagined that at some point we'll be able to keep them stable for months or years together. That hasn't happened. Even in acute liver failure, where we thought that this would provide a bridge to recovery, bridge to spontaneous regeneration, it hasn't really happened. So MAS or liver dialysis or any other variations of liver dialysis, including the ELADs, the extracorporeal bioartificial liver devices, they haven't lived up to their promises. So those are not alternatives to transplant really. For portal hypertension, again, there is several things that we do all the time, and we all are familiar with this. And TIPS is one thing that has served us well, especially in recalcitrant bleeders or in very resistant bleeders. But this is one thing that has really emerged. TIPS is no longer the stent that goes in and gets blocked in a year now. It functions well, and for Budd-Chiari, there is reasonable evidence now that it can be the destination therapy and an alternative to transplant, but not for any other indication. For Budd-Chiari, there is a reasonable chance. So this is a recent meta-analysis that was published, And there is good emerging evidence that the need for transplant in these patients who are diagnosed timely and tipped timely, the need for transplant is only about 5%. So these are possible only in units that are interested in vascular liver diseases. Otherwise we miss Bud Chiari all the time. The second emerging actor was antifibrotic drugs, and these were a group of drugs that were not just antifibrotic. They would have anti-inflammatory actions, they would suppress the HSCs. There are several of these actions that these different drugs would have, and several of these drugs are in various stages of clinical trials, none in advanced stages like to be ready for clinical use yet. But their problem is the large amount of toxicity that you see with these drugs. And again, the drug doesn't really understand whether it's supposed to only remove the fibrosis from the liver. It has a lot of side effects because it's a systemic drug. And therefore, we are not ready for prime time with any of the antifibrotic drugs yet. For acute liver failure, again, we know what to do. We manage these patients well. There are couple of things that have really changed the game here. One is that we now understand retol poisoning ALF much better. And in the past, we used to offer transplant to a lot of these patients. Now we offer a plasmapheresis to these patients. And the spontaneous survival in these patients with plasmapheresis without transplant is more than 70% in most centers now. There is CRRT, which we do, and most other centers have started doing that now, which prevents cerebral edema. And in the past, we used to have about 20% patients dying of cerebral edema and coning. Now it's, in our experience, about out of 150 patients, one patient was lost to cerebral edema related mortality. So this is again a game changer. Although unfortunately, we do not have level 1 evidence in support of this, which will happen at some point. And we also realize that hepatitis A and E have very good spontaneous survival rates. So most centers now delay doing transplant for these patients and get away with spontaneous survival. So in our series of about 150 ALFs, we have about 80% spontaneous survival in A and E. We don't have paracetamol, but again similar rates of spontaneous survival are seen in West now with paracetamol. And the DILIs and the subacute liver failures are the one who do not recover. So they have almost 80% chance of needing a transplant. So spontaneous survival is really an alternative to liver transplant in acute liver failure within certain indication, which was not in the past. You know, the moment you saw INR of 8, you would just go and transplant them. No longer for retol A and E, I mean hepatitis A and hepatitis E. Again here ALF, Mars and Prometheus and even hepatocyte transplant has not lived up to the promise. So sad, but that's where we are. So, you know, all the literature about Mars, all the studies, the good things are, outcomes are in column number 4, and you'll see that all of them give you better bilirubin, make you temporarily better neurologically, keep your hemodynamics better, but no improvement in survival. Even in the recent studies, no improvement in survival. They give you a patient who looks better, who is more stable for a short period of time as long as you're doing the Mars. But the moment that's gone, the patient has no advantage. As far as hepatocyte transplant is concerned, originally it was hypothesized that it will be a treatment modality for inborn metabolic diseases as well as acute liver failure. For acute liver failures, we haven't, it has been tried and several publications, but it hasn't really lived up to the promise. Between the two groups, the main difference is that the UPMC group delivers it intraportally, and the King's group gives it intra-abdominally after encapsulating them in alginate. And they have seen better success. So the King's College protocol of giving it in the peritoneum after encapsulation is better. The results are better. So again, these are every single case of hepatocyte transplant that has been described in the literature, and you'll notice consistently that you will see better bilirubin, you will see some benefit. But everybody, almost all of them end up going to a transplant at some point. And that's an option that's available in the West. We don't have that option. So if hepatocyte transplant fails, then our patients will probably die. And then the same for factor 7 deficiency, glycogen storage disorders, phenylketonuria. So we haven't seen either no benefit, or we have seen benefit that is not sustained. And now there is emerging thought that this is not a one-time therapy. You just got to keep doing it every 2 years or every so many years, and that might work actually. It has also been done for urea cycle disorders, for which even liver transplant really doesn't work well, except for few. And then here again you see ammonia reduction, urea production which is better, but no improvement in survival. They all need a transplant at some point. And this is for OTC deficiency, which is where a great amount of benefit is seen, a rare disorder, but still either they all go to transplant or die. So it's not proven to be a very good modality. But again, in OTC deficiency, there is emerging thought that if you keep doing it every year, then it may work well. So it hasn't worked, this is the same point in so many words. For HCC, again, there are several treatment options we know. There are several pictures after this, but in short, for HCC, which is within 2 centimeters or within 3 centimeters in size, the outcomes of transplant are equivalent to the results of RFA. That's one thing that is clear in literature. Other than that, the rest of it, all of us know this. You do a PEA or we do RFA. In which situations RFA, in most situations RFA is actually superior to PEA. And then we also have microwave, which is suitable for tumors which are not really suitable for RFA. And then for tumors that are small, up to 4 centimeters, the results are similar. We all know about TACE and various ways that TACE can be done. And all the TACE and the TARE, most of them have very similar efficacy, except TARE, which has now been shown to have a slightly better 2 to 3 year survival compared to TACE, although it is prohibitively expensive, especially for a country like ours. So in summary, antivirals are really effective and they have changed the field of liver disease. Lifestyle diseases are increasingly causing liver cirrhosis, but they can be controlled, and maybe reversal of fibrosis may be a possibility in the future. None of the liver dialysis methods have lived up to the promise. Hepatocyte transplants does have a transient benefit, but it may be required often. Infusion may be required often. For non-cirrhotic HCC, of course, there is, if it's resectable, resection is the first choice. But for cirrhosis, if there is a tumor which is up to 2 centimeters, RFA may provide an alternative to transplant, but not any tumor beyond that size. Thank you very much.
Thank you. Excellent presentation and perfect timing. Just one question, that we often have this situation, as you flagged today, that ALF, INR is 8, and it's hepatitis A. Yeah. And it's been there for a few days, and it's typically INR is the one we keep looking at, but that even if one gives, the gastroenterologist, the intensivist gives plasma, it keeps, so how do we actually decide when to transplant?
Yeah,
how late?
You have to have at least one parameter that you can follow, and typically we don't do plasmapheresis, we do CRRT. Our goal is to prevent cerebral edema. And INR is your decision maker. INR, because even you will lose lactate as a parameter, you will lose ammonia as a parameter, you will lose all parameters. But as long as you don't give plasmapheresis, INR is your friend. And then typically
once it's 8.
No, so even if it's 8, I'll wait until the patient starts having rising ammonia on CRRT or rising lactate on CRRT. I would not do the transplant. And we have had several situations and very intense fights between the intensivists and us, and we have been able to salvage most patients who with INRs of 8, and then after 2 days, and they dramatically come down. Once they start coming down, it's like 8, after 12 hours 4, and then it's 2, so it's so unless they are not able to maintain their ammonia and lactate on CRRT, I would wait.
So nice, Dr. Ravi. Yeah, I was just wondering about the publication by S.K. Acharya.
Yes, sir.
Have you gone through for the acute liver failure and Mars?
Yes,
And
sir.
he has shown some improvement and some percent, I don't exactly remember, but the article was published in Journal of Hepatology and
Yeah.
Gastroenterology, I think,
Yes.
few years back.
So no benefits in survival. There are several benefits. There was
Recovery, if I remember correctly, some percent of the patient they recovered from the acute liver failure.
Yes, sir. And now what has happened is that our understanding of which patients will recover has changed. So about 5 years ago, we would transplant all these patients, although they have the potential for spontaneous recovery also. And even if we did Mars or if we did
Don't do
CRRT,
it.
they will have the same result. So therefore, I think that because Mars is mounted on a CRRT, a regular dialysis machine, and they're getting the benefit of dialysis also. So my assumption is that the benefit was actually because of dialysis and not the additional Mars that was happening.
Thank you.
Yeah.
Dr. One of the conceptual issues, see, DCD,
Yes, sir.
so it's a large organ pool, okay? So if it, so the challenges, let us say in xenotransplant, the money spent, the challenges, the regeneration, hepatocytes and all that.
Yes.
The challenges, what do you think that is challenges in making DCD?
Sir,
It is less complex and less challenging and a large organ pool opens up.
I agree with you, sir. And yesterday we had this meeting, ISOT, and I gave a talk on this. So we know that there are only 2% deaths are brain death. 98% deaths are circulatory death. So this is a large pool. Now, out of the 5 types of DCD, the Maastricht criteria, in India, type 3, which is normally done in the West as a controlled DCD, is feasible in India, but with 2 things. One is that the family has to say DNR, and now we have AIMS and ICMR guidelines for DNR. So in the past people used to say that DNR is not allowed in India, but that's not true. We have guidelines to do DNR in India. So if there is a patient who is terminally ill and we know that they are going to pass away at some point and the family says DNR, then we combine this with NRP, which is normothermic regional perfusion. So basically you keep a ECMO or a cardiopulmonary bypass next to the patient bedside, and the moment there is cardiac arrest, because we are not going to do resuscitation, therefore after 5 minutes of waiting we certify them in a normal death certificate, and then you institute NRP, which will generally take about 15 minutes, and as long as this is done within half an hour, it is very successful, and that is what has changed the face of DCD in the outcomes of DCD in Spain and in UK. This is going to work for India, and even by very conservative estimates, it will probably increase the organ donation rates by about 5 times.
I think very nicely you explained. See, when you explain in 2 minutes, it's very clear that there is no roadblock. Okay.
Yeah.
So unfortunately, this is where we do not push what is feasible in India. So that's what I feel. And Westerners, depends upon the social systems in their country. As you mentioned, the 2 countries very specifically, they have a subsidized social system. So they promote it, whereas systems based upon more profit-based, they promote xenotransplant. This is what my impression.
Sir, this year we have published a paper in Indian Journal of Critical Care Medicine and Indian Journal of Transplantation. It is a consensus statement of 8 societies, the Critical Care Society, Neurology Society, all transplant societies, and we have laid out a SOP, a guideline, and of how to do DCD in India. And every form, all documentation that is required for making this work is also part of that article. So I urge everybody to start doing DCDs by following that SOP. It is possible in India. I am very passionate about making it work, sir.